Okay, welcome everybody to our webinar. Hopefully you've got the email that was sent out with the joining instructions that just advise you that the presentation is going to be slightly different to what we had planned. We will include some resources and signposting around the Mental Capacity Act. So welcome to everybody. We are recording the session, so with the view that it will be placed on the SSP website so that colleagues that were unable to attend have got this available as a resource, because it will feature learning from our local case reviews and audits. So if you haven't already, could you please put your name and role in the chat just for the attendance register so that we know that you've attended, that kind of housekeeping. And then just as an idea and helpful for our presenters, who are Helen and Debbie, and I'll let them introduce themselves before they start, just so they've got an awareness of who's coming and from what agency. And then if you have any questions, if you could put your hand up or pop into the chat, and then Debbie and Helen will be able to answer those questions. Confidentiality, just a general reminder that if you do want to ask any questions and you're going to kind of use a case example to anonymise that example, particularly in light of the recording, we'll post a link in the chat towards the end of the session, which will be to the evaluation form. So really appreciate your feedback, because this is probably one of the earlier webinars that we've delivered, so it's really useful to have a feedback and kind of future development of what we would look to cover and your comments and observations. And then if you do need a certificate for your professional development, we'll provide some information about how you can obtain a copy of that. So I will now hand over to Helen. If you want to give your introductions, Helen.
Morning everyone, I'll just put my camera on for this bit. I'm Helen Rankin, I'm a development manager in the business support unit of the Safeguarding Partnership. So the Safeguarding Partnership is all of you, and the business support unit, we're there to coordinate and lead some of the work on behalf of the partnership. So from today I'm going to be looking at the Mental Capacity Act audit and some learning that came from that. And then we're going to be talking about safeguarding adult reviews. So there was a national review of safeguarding adult reviews and some analysis done, so we're going to be looking at that and then talking about local case reviews as well. Okay, Jackie, I'm ready when you are.
Okay.
So in 2020 there was a multi-agency audit to look at how agencies across Swindon were applying the Mental Capacity Act code of practice when an adult who is the subject of a safeguarding inquiry lacks capacity to make a specific decision. So this audit involved SSP Adults Safeguarding, Wiltshire Police, the CCG, the Ambulance Service, AWP, the mental health provider, First City and GWH. It also included the third sector and the fire service. So colleagues were requested to provide information about one case. They'd completed at least one mental capacity assessment and where at least one other agency was involved. And then practitioners presented their case to a critical reflection workshop, and there was a peer panel there to review the cases, and then information was drawn together as to what the outcome was of the audit. So there were a number of themes that were drawn out of the audit, many of which we see still are very prevalent, particularly in the safeguarding adult reviews that we have locally. So the findings noted often the interface around the Human Rights Act of 1998 and the Mental Capacity Act 2005 needs to be clearer to staff. And there was wider work for the partnership to look at support for staff, including training. And as you'll see from these slides and later on, there's been a lot of work done around this and that is available to practitioners now. And they identified difficulties around how consent was gained from individuals who were subject to a safeguarding referral and a Section 42(2) inquiry, and practitioners' understanding of how that could be overridden and the rationale behind that, for example, if the individual was in a situation of domestic violence. They noted in these cases that the recording and documentation of mental capacity assessments and discussions, including the reasons behind the decision making and what was identified in discussions, were not necessarily consistently recorded, which made it difficult then when other colleagues were involved later on in the case. Many of the cases presented including elements of self-neglect and hoarding. And as you are hopefully already aware, we have refreshed the self-neglect policy and the hoarding guidance. but that was an outcome of this particular audit. They also noted that MCA assessments need to be time and decision specific to protect the person, and it was important that these were noted in case notes. There were issues where colleagues were not always escalating concerns within the adult safeguarding team or in the wider partnership, and that it was identified that there was a need for a formal escalation process, which is now available. There is the SSP Adult Escalation Policy, and there's also equivalent in children's as well. And they identified that in the initial assessment, there was a lot of backwards and forwards between agencies, and it wasn't always clear who was responsible for doing what. And the adult safeguarding team were not always informing practitioners of the progress of their referral, or once a case was closed, what the outcomes were. So there was a number of learning items identified there. So recommendations in relation to that was for the SSP training offer to include Human Rights and Mental Capacity Act and legal literacy around this. So that is now available. The development of separate self-neglect and hoarding policies. So we now have the multi-agency policy and guidance on responding to self-neglect, which you can get on the website. And we've also recently produced a hoarding protocol. So both policies can be read in conjunction, but they are separate. To produce a learning brief around mental capacity decisions and the importance of recording decisions and reasoning. So you can find the Mental Capacity Act guide on the Swindon Safeguarding Partnership website. And as I mentioned, the escalation process in relation to adults was revised, and you can find the adult escalation policy on the website as well. Thank you, Jackie. So here is our 7-minute briefing on the Mental Capacity Act. So hopefully you're familiar with 7-minute briefing templates on the SSP website. We've got them for a number of topics and also relating to case reviews. So this one in particular outlines what the purpose of the Mental Capacity Act is. So designed to protect and empower individuals aged 16 and over and help to safeguard the human rights of people who lack or may lack mental capacity to make decisions about their care or treatment. So this gives you an overview of the Act and outlines the 5 principles that need to be applied when working with people and undertaking mental capacity assessments. So please do access that on the SSP website. So there's the Research in Practice guide, and there's also an easy read guide and a toolkit. So there's a myriad of information on there to support you in working with people when considering the MCA. Thank you, Jackie. So there you can see listed everything that we provide via the SSP, including 7-minute briefings, the toolkit and training. And also you can refer to information on Sky's website as well. So there's a number of resources there. Thank you, Jackie. Did anybody have any questions about MCA? So unfortunately, our colleague who has got lots of practice experience was unable to present today. So if you have any questions about that or any feedback or anything, please feel free to put that in the chat. Okay, I've not seen anything, so we'll move on to talking about safeguarding adult reviews, or SARS as they are shortened to. So under the Care Act in 2014, sections 44, 1, 2 and 3, safeguarding adult boards, or in Swindon's case, the safeguarding partnership, must carry out a safeguarding adult review when an adult with care and support needs has died or suffered serious harm, and it is suspected or known that the cause was abuse or neglect, including self-neglect, and there is a concern that agencies could have worked better to protect the adult. So they are the statutory criteria for conducting a SAR. Boards may also undertake a SAR in other cases concerning adults with care and support needs. And the purpose is to identify learning that can drive change that will prevent harm occurring in future similar circumstances. So on the SSP website, you can find out a bit more information about the process locally for SARs and details of SARs that we've undertaken. It's worth noting that we're currently reviewing our SAR policy as well, just to make sure that it is in line nationally with some work that's been done to make sure it's very clear. So should you ever be involved or asked to participate in a SAR, you'd be able to access the information to be clear on what our process is. Thank you, Jackie. So last year, there was a huge study that was undertaken. Safeguarding Adult, or SABs, or Safeguarding Partnerships, were requested to submit to the national body any SARs which they'd undertaken. And from memory, I think it was all SABs or partnerships, but 3 sent in or contributed some SARs. So from that, a team of academics and social care colleagues analysed all this information, and in the end they had 231 SARs nationally from a 2-year period. And what they did was to analyse all of those SARs to look at what were the key themes, what were elements of good practice, elements of practice which needed to be improved, and also developing guidance for SABs and partnerships on how to conduct SARs and to look at what this meant nationally. So what the analysis showed is, of all of these SARs that were analysed, self-neglect was the most prevalent type of abuse in 45% of reviews. And certainly that is reflected locally. Self-neglect is a key theme that we see in our SARs. So neglect or acts of omission was 37%, physical abuse 19%, and organisational abuse 14%, which contrasts the pattern often in safeguarding inquiries in section 42(2)s, where it tends to be neglect or omission that features most frequently, followed by physical abuse, financial or material abuse, and psychological abuse. So as when we're analysing the key themes, the National Review of SARs looked at how to split and categorise everything they found into 5 domains. So they focused on the findings related to the direct work with the individual concerned, so looking at practice specifically, looking at interagency collaboration and working together, because that's often a theme in SARs, looking at the organisational features within the agency, so that would be considering things like policies, supervision, staff resources, etc. Looking at the governance of safeguarding adult boards and partnerships, and finally considering the national legal policy and financial context. Thank you, Jackie. If you're interested in reading it, it's quite a lengthy document, but it makes for interesting reading. You can find that on the LGA website as well. But really what we've got here today is just trying to bring together the key messages for yourselves as practitioners when working with adults and things to consider. So sort of the key messages for practitioners that were drawn out from the analysis: that shortcomings in practice have an immediate and direct impact on the individual, and it's important learning for practitioners to apply in their own direct work. It's also the case that features across the other domains, so considering resources and time pressure, information sharing, coordinating cases, and poor guidance nationally can impact on direct practice. And important as practitioners to be alert to this and to escalate any concerns about ways that your own effectiveness might be compromised, including potentially what might be happening in your organisation. Thank you, Jackie. And just to say, in terms of escalation, yes, there is the escalation policy on the SSP website for when working with adults. So in terms of what the analysis drew out, they noted in commonly good practice related to how an individual's health needs were met and the application of making safeguarding personal principles, which were noted around 25% of cases, but also commented with a continuity involvement with attention to the care and support needs of the individual, safeguarding practice, and attention to mental capacity, which is very important. And then equally, when looking at poorer practice or practice requiring improvement, the key themes tended to be a failure to attend mental capacity assessments or risk management being poor, failure of safeguarding, a lack of recognition of carers, unpaid family carers, and inadequate attention to care and support needs and healthcare. And crucially, a phrase that we hear a lot, an absence of professional curiosity, meaning that circumstances were sometimes taken at face value rather than explored sufficiently to reveal an accurate picture of what was happening for that individual involved. Thank you, Jackie. So they portion them out into, this table is quite helpful to look at. So the number of mentions of good practice and practice requiring improvement. So you can see for yourself there, responding to the health needs of individuals, MSP, personalising the approach, a continuity of care or professionals involved with the individual, recognising and supporting their care and support needs, making referrals to safeguarding or supporting individuals through the safeguarding process, and the consideration of mental capacity. But equally, some of these do feature in the poor practice there, and certainly mental capacity and risk assessment feature quite heavily in local SARs, and into more historical SARS, working with carers or recognising and questioning if somebody is a carer for somebody, or if they're potentially a source of threat as well. Thank you, Jackie. So again, those key messages for practitioners working with adults: it's important to pay close attention to mental capacity, carrying out capacity assessments where indicated, and particularly in those cases where an individual consistently disregards high level of risk to themselves or others, which this is a feature of local SARS, and the potential impact of impaired executive brain functioning on decision making, and how that can fluctuate in certain circumstances at any given time. And explicit and comprehensive risk assessments, and also focusing on proportionate risk management is a key feature. Thank you, Jackie. So moving away from looking at direct practice and thinking about interagency working and organisational pressures, etc. So good interagency practice was noted in around a fifth of the cases, but often there are also features of poor case coordination as sharing information in 3/4 of those cases of the 231. The most frequently mentioned organisational feature, which would come as no surprise, was pressure on staffing and workloads in over 1/4 of the cases. So an absence of management scrutiny and training were noted, along with an absence of available resources, as sometimes this was relating to commissioning as well, so commissioning of local services. And there was also the domain focusing on the governance of safeguarding adult boards, or in our case, a partnership. Noted an absence of guidance, a lack of policies on key things such as self-neglect, escalation, risk management and mental capacity. So it is worth noting that the SSP, we have policies on all of those subjects, but this learning from national SARS is driving a lot of work nationally, and there's a lot of quality markers and work going on to make sure that our safeguarding adult reviews are the best that they can be, and that we're supporting practitioners as much as we possibly can. Thank you, Jackie. So just to sum that up, really, in the key messages that we've taken from this analysis. So factors such as poor case coordination, information sharing, pressures on staffing and workload, availability of commissioned resources, this absence of management scrutiny and training, all of these things could compromise the effectiveness of safeguarding, but also influencing directly how practitioners in any one agency are able to approach their work with an individual. So as practitioners, having an awareness of these factors can assist you to take appropriate actions, for example, to work quite actively in terms of collaboration and working with other agencies and sharing information, and to escalate difficulties and concerns where you have them. And it's important for us all to learn the lessons from safeguarding adult reviews locally, but also regionally and nationally, to draw on the evidence base to improve our own practices. And really that key message is that frontline practitioners, you are in a position that has huge potential to make a difference to the outcomes of safeguarding for the individuals that you work with. And hopefully by reading through some of this information and having the awareness of these pitfalls, it can enhance and improve our practice. Thank you, Jackie. Is there any questions on that one before we move on to looking at our local safeguarding adult reviews? No, I'm just going to check the chat, but I don't think there was anything specifically. No, okay. Thank you, Jackie. So since the formation of the Safeguarding Partnership in 2019, we've had 4 published safeguarding adult reviews, 4 published SARs, and we currently have 2 that are in progress. So the following slides here are learning leaflets. So they summarise the key themes for professionals and include links for further information. So they're available on the SSP website. Hopefully you may be already aware of them. You might previously have read them. You might have had them delivered in a team meeting, or they've been highlighted in communication from the SSP. And if not, they are really useful resources. And if you want to be added to the SSP newsletter, if you're not already, you can just put your information in the chat, because when SARs are published, we do include information in the newsletter and links to those. So the full SAR reports and executive summaries are available on the SSP website, and the executive summaries are only 2 pages. So they're often a bit more manageable to read, and then they complement the learning leaflets as well. So this is for SAR Terry. So this was in 2019. So in June 2019, Terry died in hospital, age 71, from liver cirrhosis, accompanied by hepatitis C. So he'd experienced self-neglect, financial exploitation, alcohol dependency in the years leading up to his death. And in November 2019, SAR was undertaken, and key areas for learning were identified, which is what this learning leaflet sets out. So there was recommendations and themes around making safeguarding personal, around the Mental Capacity Act and assessing mental capacity. And again, we've already touched on the resources that are available there. Self-neglect was a big feature in Terry's life towards the end. And as we've already mentioned, that and the MCA audit did result in some movement towards improving our self-neglect policy, and it's in fact been completely rewritten as well, and that's available now. And we also have specific training modules through the SSP on self-neglect as well, which I would highly recommend attending. They're really valuable. And if you know nothing about the subject, then we've got an introductory one, half a day module, which is really informative and links to a lot of the information in the policy. There's also a consideration around risk assessing and risk management as well, particularly around individuals who refuse a service and refuse to engage, but there is a concern about are they self-neglecting, are they at risk from themselves or others, and how we can support them. And also around multi-agency working, so that importance of communicating and sharing information and working together to support an individual. So they were the key themes around Terry. Thank you, Jackie. So quite closely followed by SAR Kieran. So Kieran died at home in January 2019 following a period of illness. So he'd been diagnosed with mild learning disabilities around the age of 18 and had first had contact with mental health services following his father's death 3 years later. And Kieran lived with his mother until she passed away in early 2002. So Kieran had experienced self-neglect and hoarding, mental illness and exploitation in the years leading up to his death. So again, you'll see some similar themes here. So Mental Capacity Act and how that works with the Care Act. Concerns about how to support someone who is hoarding or showing hoarding behaviours, how to work and best support people who are not engaging with services as well, and the importance of record keeping and sharing that information with colleagues who then can potentially pick up the case, and more around exploitation. And we've had some more recent SARs where they've been concerned around exploitation as well. So a lot of work's been done around that, and there are some resources that you can access on the SSP website about that one. Thank you, Jackie. So then in terms of more recent SARs, we've had SAR Alison. So Alison was a 49-year-old woman who had taken her own life in June 2020. She had an extensive history of trauma, chronic mental health problems and a pattern of alcohol misuse. She'd been engaged with AWP for at least 25 years and had quite significant mental health difficulties over the duration of her life. She also had poor physical health. There was a suggestion that she might have been subject to exploitation by her neighbours, and as a result of this safeguarding adult review, further commissioned an additional report looking specifically into criminal exploitation and how we should best respond to that. And that is due to be published in a couple of months' time, and that will also be on the SSP website. And we're developing resources around how to support practitioners to work with people around criminal exploitation. So last November, a SAR was undertaken, and we identified various areas for learning. Thank you, Jackie. So this is on the next couple of slides. So the report considered multi-agency working as well, and looking at multi-agency risk assessments and capacity assessments as well. So even though an individual may be predominantly working with one service, there will be other services involved. So how do they join up that risk assessment to keep someone safe as best we can? So those link quite closely together. Again, around the Mental Capacity Act, but this was looking specifically around fluctuating capacity and the impact of alcohol on capacity at any given time, and how that could impact on someone's capacity and ability to make a decision and understand the consequences of that, particularly looking at their health and their care and support needs. Thank you, Jackie. This one also looked quite significantly at the role of alcohol and some best practice suggestions around services which support someone in treatment, and also the impact of smoking on mental health, and also the impact on hepatitis C on cognitive functioning and mood as well. This author in particular had an interest in that and was able to provide some information in the report about the impact of hepatitis C on cognitive functioning and how that might have impacted and impaired Alison's abilities to carry out certain tasks day to day. So that's something that's quite interesting to read. And again, exploitation was a key theme. So as I said, we've commissioned an additional report to look into that in more detail, including on how to respond to that. So there'll be some more information to come. Thank you, Jackie. So just before I hand over to Debbie, so we do have another SAR Andrew, which has been published, and that was looking at around coercion and control, intergenerational domestic abuse. Were some key themes there, and again, non-engagement with services and understanding the role of somebody as a carer who may be a protective factor but potentially a risk as well. So there's information on the SSP website about that one, and we have 2 SARs which are currently being written, and they should be published in the autumn. So again, once those are published, you'll be able to access information on those. Does anybody have any questions? You don't have to ask now, you can always put them in the chat if you reflect on anything. Okay, in that case, I'll hand over to my colleague, Debbie.
I'll quick put the camera on. So my name's Debbie Greenoff, and as Helen has said, we are in the business BSU team within the CSP SSP. I'm part of the community safety partnership, and I'm a development manager for there. So I oversee the risk enablement panel, the MARIC, prevent and channel. So I'm going to today give you a quick overview of what the risk enablement panel is. Thank you, Jackie. So in Swindon, we have the multi-agency risk enablement panel REP, and it's been active for approximately 7 years, and it is not a statutory service. So hopefully from what I'm going to tell you, you'll have an understanding of how it works and links into the SARs that Helen has just gone over. So in 2020, the risk enablement panel was embedded within the Community Safety Partnership, and now the Swindon Safety Shark Partnership Business Unit. Previously, it was managed by the Community Safety Partnership, and this was aimed to coincide with resources from the police and adult safeguarding. The panel was set up following the outcome of an adult case review, which highlighted the need for more coordinated approach with dealing with people who have chaotic lifestyles. There was a lack of recognised and understood multi-agency framework for case planning and decision making in Swindon, which led to inconsistent and reactive practice, resulting in ineffective support for vulnerable people. As Helen's already said. Thanks, Jackie. So agencies in Swindon recognise that there are a small amount of individuals who have multiple needs and need to be and may be at risk of significant harm, but fall outside the criteria for adult safeguarding investigations, or who have made capacitated decisions not to engage with inquiries. The risk enablement panel cases are often those who are marginalised by society. They are in most need of in-depth assessment due to their complex presentations, but are often those who do not attend appointments at appropriate times and so are closed to services due to the lack of engagement. So the risk enablement panel clients often incorporate mental, psychological and/or emotional health needs, learning disability or difficulties, drug or alcohol dependency, both, economically inactive. They could be in entrenched street homelessness, being vulnerably housed, financial and other areas of exploitation, histories of contact with the criminal justice system, have physical health needs, may experience domestic abuse and sexual violence, could be sexually exploited, and have self-neglect and hoarding. Thanks, Jackie. So these are the clients who often fail to engage or maintain engagement in core services, including wider health and social care services, but still have multiple needs and issues that can be addressed by a spectrum of public services and third sector organisations. So the complexity of these health, social care and community safety needs often act as a barrier to engagement. It is often those with complex needs where the threshold of engagement is beyond their level of ability and or motivation, so clients become highly socially marginalised, stigmatised and lack of social supports and community integration, and can often become isolated from services, which may then classify them as treatment resistant, intentionally homeless, hard to engage or making unwise choices. And the working time with these individuals can be years due to their complexity and engagement strategies. Thanks. So the REP process will only be enacted when all other interventions have not produced an improvement in outcomes for the individual of concern. So the role of the REP, Risk Enablement Panel, is to facilitate, develop engagement and risk management plans and monitor their effectiveness. So we don't take over. What we do is we facilitate. So the criteria for cases that can be put forward for the Risk Enablement Panel include the person concerned being deemed to have mental capacity. So we will only work with those who have mental capacity. If they don't have mental capacity, then they would have to look at a different process. So overall, the Risk Enablement Panel process is about concentrating on what can be achieved rather than what cannot, and bringing people together from different organisations to develop shared perceptions of risk. Thank you. So the REP is for those who are deemed to have capacity and who are at risk due to severe self-neglect and self-harm. They have risk-taking behaviours. They are change resistant. They refuse to engage with services. They have experienced abuse by a third party but are not willing to engage in the safeguarding process or with services. They are frequent callers to services and where the agency is struggling to maintain a high risk situation as a single agency. So that is our criteria. Thanks, Jackie. So the purpose of the risk enablement is to share information to identify, clarify and agree on risk, promote the safety and well-being of high-risk adults in Swindon, improve multi-agency communication pathways, utilise the resources in Swindon more effectively, develop a risk management plan. And for those who are not engaging, coordinate a risk management plan to seize the opportunities that can enable engagement and or monitor the well-being of the person. For example, use outreach opportunities, support from the community and locality input. It's also to ensure any actions are covered by a legal framework or are lawful. Improve agency accountability, identify a lead key worker and share risk across agencies, and also to consider the options that will enhance the range of possibilities available for professionals to improve the outcome for the individual. So part of the referral form is a risk assessment, and the risk assessment process is a proactive tool that helps to identify hazards and assess the risk. So we're looking at something that will be potential to cause harm and the likelihood that that hazard will be realised. So the risk assessment is very simply the process of thinking about what harm might possibly arise from doing something, identify who might be harmed and how, evaluate the risks and identify what can be done to support the people, record risks and the decisions made, review the assessment at the of the risk at appropriate intervals, and then look at how we judge and evaluate the risks. The risk assessment will look to ensure that people are safe and not put into situations where they could be harmed, threatened, exploited or abused. There can be a delicate balance between risks that are part of living a full life and being placed at risk or in necessary danger. Thanks, Jackie. So this is how we assess the risk. If the risk is scored at 10 or above, the expectation would be that it sits with REP. Between 1 and 10, this should be managed through the multidisciplinary teams. So this is our basic risk. Sorry, I started reading. I won't read the comments yet. So what we're saying, that if someone is identified as being 1 to 3, they're green and they will be contained within a support plan. However, if they scored between 10 and 20, it would be suggested discuss the risk with their manager immediately and then consider risk enablement panel. And then if it's 20 to 25, act immediately, consider 999 call, ambulance and or police. However, if it's appropriate, if they are scoring between 20 and 25, we will support with REP, but we will also engage the police and other services involved as necessary. Thanks, Jackie. So this is an example of one of the criteria. So this is risk from others. So if the person you're referring has moderate, which is evidence of probable risk and stable or frequent changes in the situation, they need the services and or professional input, carer, service user, concerns for independence, the individual's ability to manage the risks they face is limited, we would consider that to still be managed between the multi-agency teams. However, if they turn to high, which is evidence of actual serious risk, safeguarding issues, unstable situation, vulnerable with very little support, very few coping strategies, major threats to the independence, and the need is now, that would be classed as high and suitable for REP. Thanks, Jackie. So the second part of the referral form, which links into the above risk from others, we would be expecting the referrer to be able to consider this as risk to others. What risk to others are there about psychological abuse, financial or material abuse, neglects and acts of omission, discriminatory abuse, culturally isolated situation, transitions, leave in children's services, human trafficking, and any strengths and skills. So what we would be expecting would be for you to be able to complete the form to say that yes, there's concerns about psychological abuse. If you know that there was in the past as well, please add that in, or if you don't know, say you don't know. But to fill the form in as complex as possible so that it gives us a really good overview. Thanks, Jackie. So there are several areas to the referral form. So there's risk of self-harm and suicide, self-neglect and hoarding, there's risk to others, risk to children, physical, risk of homelessness and challenges to services. All these areas have the same format as the previous 2 slides. Thanks, Jackie. So just wanted to give you a brief case study of one of the cases that we have worked with. So she was a woman in her 40s. The areas that were highlighted as risks were risk from others, risks of self-harm, risks of self-neglect, risk to others, physical, risk of homelessness and challenges to services. So risk from others, she was assaulted by an ex-partner. threatening behaviour, probation involved, which was due to end, and taken advantage of by others. Risk of self-harm, she was a polydrug user and alcohol dependent. Professionals reported not taking rehab placement seriously, possible suicide attempt, and significant life event which was her child no longer wanted contact. Risk of self-neglect and hoarding. She was diagnosed with DVT, and continually self-discharged from hospital. Hoarding was to the extent that the fire service assessed her as 5 to 6 out on the clutter scale. Where am I? Failing to drink properly. She was using alcohol as fluid intake and failing to eat properly, lack of positive social contacts, difficulty in managing physical health, and experiencing financial difficulties. And then risk to others, antisocial behaviour. She was urinating in the town centre and was arrested by the police for drunk and disorderly. There was low-level common assault. Stated will resort to committing crime to get support needs for mental health and substance misuse services. So her physical was risk of accidental injury inside and outside of the home when intoxicated, and risk of alcohol-related seizures, and risk of untreated DVTs. And there was a risk of homelessness. Although the property was owned by family, the ASB concerns around her meant that there was a risk of her being made homeless. And the challenges to services, which is usually the biggest one, is there were negative behaviours. Her negative behaviours were escalating, and the services were struggling to engage and support. Different reports of behaviours have been reported to services, so there was no clear picture of the current risk. Fluctuating capacity due to intoxication, she was making unwise decisions. Frequent hospital self-discharges, she would often discharge before medical treatment could be completed by the hospital staff. She's not engaging with Turning Point and the Tier 4 pathway for detox and rehab. Had she been offered many appointments where she did not attend or attended and then remained outside drinking instead of actually going into the supports. And there was a high number of calls to police and these calls were found to be inappropriate on response. So the actions that we put in place were, we identified a key worker, and that key worker took on the role of supporting with all GP, GWH and Turning Point appointments. We served an injunction to stop her entering the town centre, and this was done in conjunction with the SBC legal team. We put a referral into Marriott for the domestic abuse. We put a referral into the Live Well hub regarding her hoarding. PCLS appointments were organised, and she was taken to those with her key worker. PCLS and Turning Point linked together to regard the dual diagnosis and attended meetings and the panel. Turning Point liaised with GWH to organise a detox when she came into A&E. So every time she was in A&E and was there for some time, detox would start. GWH safeguarding updated the rep when she came in and out of GWH. So we had a good relationship with safeguarding, and they would keep us up to date on when she'd come in, when she'd left, and the reason she'd left. So we always knew where she was. PCLS identified an outstanding section 117. So after a long period of time of working with her, we found out that there was this outstanding section 117, which was the answer to everything in the end, it turned out. She consequently broke her injunction. She was arrested, went to court and went to prison, where she was able to receive detox and the start of rehab in prison. Once her sentence had finished, she was then hospitalised and received further rehab. But because she had her section 117, she moved from the prison hospital straight into the care of the PCLS, and there she was close to rep. So she's now under control, under the care of the PCLS, which was a positive outcome. However, had it not gone as planned, we would have had to, with the support of the agency's commissioners, the legal team, the police, and head of services, we would have had to have escalated this further to agency head of services to be able to find an alternative way of working with this lady. There are links to the referral form on the the SSP website. And is there anything that you'd like to ask? Is there anything on the chat? Jade, how do people get referred into rep? No, they don't have to be SSP staff. Anybody can refer in, and yet the referral form is on the SSP website. Yes, the sharing of information is under the umbrella of, yeah, we have lots of sharing information. Thank you then. Yes, clarity between the safeguarding process and rep. So there is a lot of confusion at times, but what's usually happens is safeguarding will close the case, and because they have no further safeguarding concerns that meet their remit, and it will then come to social care. It will then come to rep. It can also work the other way, that rep will be working with a person, and then we can see that this risks have escalated, and we will then refer into safeguarding. There is a lot of confusion, but we are fortunate we usually have a social worker on the panel so that we have clarity on who should be working with who. I think 16 years would be a good age, because at the moment I'm having a lot that are coming in from 18 where there's transition issues. So that's, yeah, exactly, picks up transition. Thanks, Jackie.
Lovely, thank you, Deb. So tends to echo those. So thank you, everybody. I'm just going to move on through to, there's some additional resources that were touched on by Debbie and Helen, which are on the SSP website. So I can send out the presentation if that would be helpful to people after this session. And then I will post in the chat about accessing the evaluation form. Apologies, because I'm presenting, I can't always see the chat. So let me just come out of that. Are there any other questions for either Debbie or Helen? So in the chat, I'm just posting the evaluation form. So we'd really appreciate your feedback around this session. We're also, there's a guidance document about how you can download a certificate on completing the evaluation form. If you haven't already put your name into the chat, could you please do so now so that we can just capture and represent everybody who has attended the session. As I say, I will send out the PowerPoint to you all so that you'll have access to the links that are included. Second from last slide up. Okay, bear with me. I will do that shortly. So yeah, I will send out the presentation to you and you will be able to get the links and everything from the session. Are there any other questions before we finished? Hopefully you were aware that it might finish shortly. Slight difference on the presentation that we were planning to give, but unfortunately one of our colleagues wasn't able to attend. So I hope that was helpful. And I will just get the slide back if you just bear with me 2 ticks. Are the slides up now? Can anybody tell me?
Yeah, we can see that about the evaluation form. Yep.
Was it this one? Was that the slide that people wanted, or do I need to go back one more?
One more, Jackie, if you can.
One more.
Yeah. Oh, Jason, Jason, was it the one you wanted around the list of resources? It's just some people typing, Jackie.
Okay, no worries.
I think it is the one with the links. So just go skip forward one. Yeah.
That one?
Yep.
Thanks.
That's the one. Great, thank you, Jason.
Are we all done? Is that okay?
Yep.
Lovely. It's difficult to gauge with Oh, thank you, Jacob. It's very kind of you. Well, as I say, we hoped it was helpful just to give a brief overview of the various things that are happening. Please keep a look on the SSP website. I will send the PowerPoints out to you. So thank you very much for your time.
Thank you, everybody.
That's the end of the session.
Thank you very much.
Thanks all. Take care. Bye.